Okay. Somshekhar sir, we can start.
Yeah, good morning, everyone. It's a pleasure to be here for the e-course for preterms for the doctors, and a lot of doctors have participated in the Telegram group, and we can see a lot of activity and questions from both the faculty members as well as the participants. It's a very interesting group with lots of relevant questions and answers, with mainly people searching for evidence and processes for doing it. So I'm very happy that a lot of people are asking what is the evidence for this answer that you're giving. So that's a very good way to approach newborn care. Today we have all our faculty members for this particular week present. They will share a few slides, and then we can continue to take questions for them during this live session. So we have Dr. Praveen Venkatagiri from Bangalore, who would be doing it first, followed by Dr. Asim Malik from Kolkata, Dr. Shwetal Bhatt from Baroda, and Dr. Rita Bora from Assam, Dr. Kavita from Goa, and Dr. Mala from Lucknow. So we would have each of them give presentations for a few minutes, and then in between I can keep on typing your questions through the YouTube channel, and we'll continue to ask them questions throughout the session. We can have questions for them immediately after they finish, or even after the end of all the talks. So please go ahead and type your queries into the YouTube chat box, and we will continue to answer them as the session goes. So I would request, I think if Dr. Praveen can begin sharing his presentation right away, and we can go to the next one after that. Please put your questions for Dr. Praveen. And we'll continue to take the questions. Thank you very much. Perfect. You can go ahead. Dr. Praveen, can you start presenting?
Sorry, I was muted, so I just... Dr. Nimaka, you can hear me, right?
We can hear you clearly. You can go ahead. We can see the screen. Please go ahead.
All right. Thank you. Good morning, everyone. And thank you for those wonderful discussions. And I learned a lot through the discussion. So this morning, quickly, we will look at what is the burden and consequences of neonatal hypothermia very shortly. So hypothermia, where do we see that? Obviously in the hospital, it could be at the time of the admission, which could be from inborn admissions or outborn admissions. And less recognized probably is during their stay in the NICU. Sometimes the hypothermia can occur, which can have serious consequences. The other side is in the community, and both term newborns who are there with their families, or the newborns who get discharged and go into the community, they do continue to have the risk of hypothermia. And the hypothermia risk is everywhere in the world, irrespective of the climate that the country has. As shown in several network data, as given here, like Canadian network, European network, Brazilian network, USA network, all have documented significant incidence of hypothermia on admission, even up to 60%, as we could see there. In Indian data as well, whether it's data from Delhi, up to 60% as a part of the quality improvement program, they have documented, or from NB Mathur, which was the outborn admissions, even up to 72% of the outborns were hypothermic in that study. In the community, it varies, and irrespective of the seasons as well, the hypothermia is seen around the country. This were in this paper about 11 to 45% of the newborns were documented to be hypothermic and had very significant and serious consequences related to the hypothermia. And when they have more morbidities, other morbidities, hypothermia worsens the outcome as well. Next, what are the other consequences? The mortality, when you look at it, LabTech have done a lot of publications on that. Every 1 degree increase in the admission temperature, the mortality has decreased. So that means every 1 degree less on admission, it's about 28% risk of mortality is there. And apart from that, several other morbidities are also increased in babies with hypothermia. And another interesting one published in JAMA 2015 are that comparing to the degree of temperature, so the lesser the degree on admission, the higher the mortality. And it's like a U-shaped curve, as we know in many of the conditions when you look at the gestational ages as well. The best outcome was seen at 36.8 degrees on admission. And it's important to note and recognize that the higher the temperature on admission is also not good. Hence, overzealous warming of the baby or using plastic bags in every baby, we should be careful about it. We should be monitoring closely and avoid hyperthermia. So what are the consequences of hypothermia? Obviously, we all know TABC. Without the temperature, the other systems, even if we are under control, we will not be able to get a good outcome. Every enzyme, every system in the body needs to be at right temperature. So temperature is extremely important. So every organ in the body can get affected depending on the length of or duration of hypothermia or the severity of hypothermia and other associated problems. So you might have lethargy, poor feeding, neurodevelopmental impairment to apnea, grunting, hypoxia, respiratory distress, or PPHN as well. You will see commonly bradycardia, hypotension, vasoconstriction, metabolic acidosis because of the alternative fuels, hypoglycemia, feed intolerance, and NAC as well. Long-term damage as well, well documented. Nearly about 40% of them in the Canadian network had primary composite outcome of death or significant neurodevelopmental impairment. Had higher mortality rate and higher proportion of the infants with poorer language scores as well. And so the take-home messages are that every center, we all must acknowledge that that's a significant burden. We cannot, if we are not measuring, we won't know, and we won't know, we then believe that the problem doesn't exist. So that's a major problem. And we kind of clearly have seen that there's increased mortality with the lower temperatures, and also the consequences of hyperthermia are also not good. So we need to create a system within our own units to document admission temperature data accurately and institute corrective measures to improve short and long-term outcomes for our newborns. Thank you.
Thank you, Dr. Praveen, for the excellent summarization of the importance of hypothermia. And it is quite interesting that the prevalence of hypothermia, when it happens, when you see it, is actually really high, around 50%, 60%. And many of us actually often do not realize it, that it is so high. In the studies you mentioned about LabTech, etc., in the US, they are mainly related to preterm babies being brought to the NICU and admitted. Even in those excellent settings where there is a lot of technology available, the prevalence was pretty high. And so one of the questions that I would want to ask you is, as far as the importance of hypothermia is that it is well known. So how do we kind of get this across to administrators or other people in the team? And how do we ensure that people regularly measure the temperature of the delivery room, the temperatures of the NICU, and to check whether the warmers are really working correctly or not? So do we need to build that into some kind of processes in the unit? Can you share something on that? Because it is important, and how to go about ensuring that the importance is understood by everyone.
Yeah. I mean, exactly. So the challenge is actually the importance is not really understood by everyone working their own units. If we ask how many preterms are coming to their unit, many people know their data. But if you ask how many of the temperatures are measured on admission, that is not generally seen. So one is first collecting the data. The moment we start collecting the data, people will start looking at, okay, there is something happening here and we can show them. So even during our rounds, we must make sure that every admission, when it comes, we look at the chart, we sensitize the nurses that the admission temperature must be taken. The importance of correcting that measures will involve even the obstetricians. In our QI, when we did the hypothermia and admissions, we had nearly almost 65-70% of them were hypothermic, but we were able to get it down to 15%, 10% like that by involving everyone, including the OT technicians, the obstetric registrars and obstetric consultants. Now automatically they themselves will start asking about increasing the temperature of the OT. So we need to look at whole system, whole chain of events, how it happens. First time you document that, what is the process of from the time of delivery or even the preparation before that till the baby arrives into the unit. What are all the steps involved? How are we doing? You could do direct videoing or even simulation. And then at each point, create a checklist mechanism to ensure that even if it is, if you have a lesser number of deliveries, at regular points, all these equipments are checked and ensured that they are corrected. It needs a system change, and the leadership must take that responsibility.
Yeah, thank you. Because hypothermia is very important, and it needs to be understood that it is not something because it looks like simple temperature, but that has consequences, as you mentioned, even neurodevelopmental consequences later on in life. So it's something very important, and we should consider it. We should give it a lot of importance, unlike what is often thought. So Dr. Sabri Gupta asks the question: hypothermia and its side effects are a concern, but till what postnatal age of the baby should we be worried about hypothermia? Is the question. So 1 week, 2 weeks, 3 weeks, 4 weeks. So what would be your answer for this particular question?
Sabri, the risk continues. We know that even as we have, of course, balances to produce the energy, and hence we burn our fat and then maintain our temperatures. So newborns especially are at risk, as we know, because of the less brown fat. I mean, at least, first 3 months to 6 months, they will be definitely at risk. The preterms, when we talk about, they are at risk because of their skin maturity and the transepidermal losses. The newborns at home are at risk because of various, depending on the environment factors or how the bathing is done, how the covering of the body is done. So that hypothermia risk continues depending on your circumstances where the babies are there as well.
Yeah. So, would you care to do you have an idea if bathing of neonates does happen in various places, and would participants comment on that? In the hospital or later on, would you know what happens?
Sorry, is that a question for me? Sorry, I couldn't understand.
Yes. Dr. Praveen, does bathing of neonates happen? Do they get bathed in the hospital? Do you have any experiences, or do you know of any such things?
Well, that's what it's a very varied practice in various. At least some 5-6 hospitals that I've seen in Bangalore itself have different practices. It's a exercise that is generally seen especially in the private hospitals as an event for a celebration, things like that. So, but typically 24 hours people wait and then they do the bathing and they teach the parents how to give the bath. But the practices are, widely different. And when and in the community, when you look at it again, there is this thing that every day bathing must be done, and without that, they are concerned about infections and stuff. But whereas it is not necessarily that that needs to be done. But there is no uniformity in the practices to what I have seen.
Yeah, so thank you for that. And maybe we'll look at more questions on bathing later on because it's relates to temperature control. Dr. Amit Suel has a question. Maybe I'll ask you this question and then we'll go to the next presenter. You have heard of wristbands to monitor hypothermia. Do you have any idea of how successful are they in home-based temperature monitoring?
The idea is sounds good, and I have tried that as well, and I have seen the studies of the use of them. Unfortunately, the settings that they were tried, the incidence of hypothermia is not so much there. So definitely, what I can tell you is that as a routine, that is not required, nor it is proven to be useful in preventing the, let's say, admissions to the hospitals or identifying severe hypothermias. And maybe it is we might have to wait for a better technology or better closing the loop of getting the hypothermic babies or the studies in the population where it really matters. But it's not a standard of practice currently, no.
Yeah, thank you. So we have done a small study on these bands. But as you mentioned, because we do not have a large amount of evidence, and most of the studies that have been done are actually small studies of 100 or 200 patients. We do not know their impact on, because generally you would want to look at impact on mortality or impact on neurodevelopmental care. So for those longer term impacts, we would definitely not have any data. You would have some data whether hypothermia was picked. So in our study that we did, we found that it picked hypothermia, but we really can't comment on whether it would be more useful. So since it is not published, I won't go into detail. Can we have a discussion as to whether skin to skin care? Maybe I'll ask that question to the next speaker. Can we have the next speaker share their slides? I think Dr. Pratima, can you share slides of Dr. Asim?
Yeah.
And he will speak on delivery room and skin to skin care.
Okay, thank you, moderator sir. We'll talk about how to do skin-to-skin contact in labor room concept. You see the next slide, please. So, labor room is the most vulnerable rooms in a hospital setup, and for the last 4 to 5 years, the conventional labor room has been changed to LDR concept. LDR means that the labor delivery and recovery room. Here, the pregnant woman spends the duration of labor, delivery, and even 2 to 4 hours postpartum in the same bed. In a conventional labor room, pregnant woman is admitted usually on the labor room only either in full dilated or near full dilated horse. But in case of LDR concept, that is labor, delivery, and recovery room, the mother admitted prior and she stays there and she is conducting delivery and then she is there at least for 2 to 4 hours. In the LDR conception, there is some provision for emergency management like forceps and vacuum delivery. But if the mothers need cesarean section or there is impending cesarean delivery like in twin delivery or in the difficult breech delivery, she may be shifted to OT for the operation. Next slide. Next slide. From 2016, NHAIIMS in India has done before. Has prepared the standard guideline for LDR unit, and in this LDR unit, you see that LDR unit consists of 4 labor areas with 1 labor table each, and the dimension is 10 feet by 10 feet. And there should be 1 nursing station. There is 1 newborn care area. And most important that each delivery should be accompanied by 1 birth companion of her choice. And because she can encourage to be present in the labor room to giving her emotional and physical support. And there should be always a newborn care area. This already exists, and the newborn area care area is consist of radiant warmer, resuscitant kit, mucus extractor, pre-warmed baby receiving towel, soldier roll, pediatric stethoscope, and so on. Next slide. And this is the dimension of a standard LDR unit, and it is different from different areas. So, with medical college, it is different. If it is a community center, there is a different. If it is a referral center, this is also different. Next slide. And immediate care of a newborn in the LDR is mainly done by skin-to-skin contact. And what do you mean by skin-to-skin contact? By skin-to-skin contact, we mean that the baby should be naked and should be placed on mother's bare chest between her breast immediately after birth. And of course, yes, if the baby does not require any resuscitation, the baby is vigorous, both term and preterm, and both normal delivery and cesarean section, the baby can be put in the mother's skin before cutting the cord. And this is called skin-to-skin contact. And most important that the skin-to-skin contact to be effective if you place there at least for 1 to 2 hours. And the skin-to-skin contact, remember that it should be uninterrupted. Most often what happens that we place the baby on skin-to-skin contact and just a few seconds again put on the warmer. This is not the effective. So to effective skin-to-skin contact, you have to place it in the mother's womb for uninterrupted for at least for 1 to 3. And as soon as you put the baby on skin-to-skin contact, it promotes the 9 instinctive stages. And you see that the stages are, stage 1 is crying, birth cry, stage 2 is relaxation, stage 3 is acne, stage 4 activity, stage 5 rest, stage 6 is crawling, stage 7 is familiarization, stage 8 is suckling, and stage 9 is sleeping. And if you don't do this skin-to-skin contact and immediate after birth, you place the baby on the radiant warmer, this instinctive phases is not there, and the baby may not be able to suckle. These pages is not there. So there are so many benefits of skin-to-skin contact. This immediate benefit and long-term benefit. And immediate benefit is here that there's so many. And to mention a few, that there is improvement in heart and lung function. There is a stabilization of body temperature. The blood sugar will be regularized. The baby should be started breastfeeding immediately. That is early initiation of breastfeeding. There is a transfer of a good bacteria from mother to baby. There is a reduction in crying, relief from pain. There is enhancement of mom-baby communication, and there is easier transition from the womb and the good maternal-child bond. Next slide. The long-term benefit, as per study from Israel study, they have followed that those who have done the skin-to-skin contact and they follow the 10 years of this child, and they found that there is a better maternal attachment and behavior. There is a reduced maternal anxiety, there is enhanced child cognitive development, and of course, there is a mother-child reciprocity is in place. Next slide. Next slide, please. And you see that the uniqueness of this skin-to-skin contact before, that at least if you've done this skin-to-skin contact for 30 minutes, it increases the milk volume both early and later in the postpartum period. And mothers of preterm babies who practice skin-to-skin contact had been found to continue with breastfeeding for a longer period, at least 6 months, from that they have the control group. These babies are less likely to have a desaturation than the control group. That's why that you see that the simple, effective skin-to-skin contact is so many benefits, and we must practice this. In our unit, that before we started a QI project, or before that the skin-to-skin contact, you have the most of the baby are kept in a one single warmer, and there are so many babies are there, and they are more than 100% are hypothermic when they are shifted to SNSU. So we have taken a project, QI project, that for the normal baby 1.5 to 1.8 kg, those who are admitted to the SNSU only for maintaining their care, normal care. And we find that the most of the babies, near over 100% babies are hypothermic. But as soon as I started the QI project and when started practicing the skin-to-skin contact just after birth, the 100% baby become the normothermic. And you see that we discussed this giving injection vitamin K, next slide, in the cot, because you have to give the vitamin K after the baby is stabilized, after 1 hour of skin-to-skin contact. And after that practice, we practice also even in the COVID situation in our there is increase of the exclusive breastfeeding rate and early initiation of breastfeeding. Next slide. Of course, there should be leadership and manpower, and there should be will. I hope that this will be the most important part, that you can practice the evidence-based practice of skin-to-skin contact in your area. Thank you.
Thank you, Dr. Asim Malik, for a very short and concise talk. I especially like the pictures of the babies, and you specifically mentioned COVID babies or COVID in during COVID era continuing with skin-to-skin care. So there's a question from Dr. Pragati, and she's specifically asking about the COVID era, how to successfully implement the practice of immediate skin-to-skin contact after birth during cesarean section. I saw a lot of questions related to this in the chat, and I think this question still remains. So if you can share how you went about ensuring that this skin-to-skin contact can be still carried out during cesarean section. So after
cesarean section, we are doing this skin-to-skin contact till now. Initially, in the few months of this, when there is lockdown, there is some apprehension of the doctors, nurses, even everybody. But nowadays, we are not, apprehension has gone up, and we are doing this skin-to-skin contact as usual at that before. No, there is no problem of doing this skin-to-skin contact, not only in the labor room, also in the OTs. There is no difficulty in there. Initially, there is apprehension.
So the question is how to get over the apprehension of the obstetricians or maybe the anesthetists. How did you go about convincing them? Because they want to know your secret of how you ensured that everyone is skin-to-skin.
There is also not so much secret. We just only do the repeated time of the meeting, convince them that, and we give them the whose recommendation that skin-to-skin contact can be done even in the COVID situation. We show them the picture, who has depicted us. So then they are convinced. Initially, they are not convinced. Everybody appears that yet there may be transmission of COVID from mother to baby, from baby to doctor, and mother to doctor, etc., etc. But nowadays, after everybody is know that what is the exact of the mode of transmission of COVID, now and after that, the decreasing trend. So everybody now convinced with that and doing that.
So to answer that question, one of Dr. Pragati, I think one of the most important things is to ensure that there is constant communication between the obstetrician, anesthetist, and the pediatrician team on a regular basis, having a monthly meeting and discussing these issues, especially recent evidence on a regular basis is very important. And maybe having an informal chat is often more useful than having an official meeting. Apart from the official meeting. So it's important to have everyone together, everyone on the same page, and discussing this is more useful. There are apprehensions from everyone, and it's only when you do it repeatedly and being persistent about what you want to do and how it helps the babies, people do come around. It takes time, but it definitely does come around. Now, Dr. Malik, there's another question. Is there any provision for using caps, socks during skin-to-skin care?
Yeah, you can use. You cannot, but you must use the cap and socks during skin-to-skin contact. It is more accepted procedure that during skin-to-skin contact you must wear these caps and socks. You can do that.
Another question is how important is antenatal counseling to ensure that the mother is primed for skin-to-skin care?
You see that our experience that mother is never object from skin-to-skin contact, whether they like it. The only objection is from our healthcare, because it's either in the doctor, either obstetrician, or the nursing part. Even the nursing part has a apprehension that the baby may fall and they can their service can be jeopardized. But you see that in LDR concept, as soon as the accompanying person is staying there, there's more easy. They can take part a role, or the nursing staff also take part a role, so they can skin-to-skin contact is now is an easy. And you see that only that you have to implement as a leadership that this is a routine basis, and there is a generous practice, and it is a human right. You cannot deprive from a newborn baby from their skin-to-skin contact, and you have to monitoring. Everybody, every day you have to monitor that. Yes, you frequently, every 7 days, I go to the labor room and in the OT to monitor that whether they are practicing or not. Sometimes there is a fluctuation, they are not doing that. But now, after repeated monitoring, they are doing that as a regular. They think that it is a system and that is a part of our usual system that you have to do the skin-to-skin contact as soon as the baby is delivered.
So you mentioned that about an accompanying person, and I think listeners and should understand that it is an intervention which has multiple benefits both for the mother as well as the baby. Having a doula or a accompanying person. So in this case, along with the mother, if the mother-in-law or the mother or somebody else is along with the mother throughout the process of delivery, either during a vaginal delivery or during a cesarean delivery, just having a person around all the time, right from before during the onset of labor till after the delivery, has multiple benefits. It has actually a large number of benefits. And if you look up the Cochrane review on having a accompanying person during delivery, you will notice that it has a large amount of benefits which have been proven much beyond doubt. Unfortunately, in many places, relatives are not allowed in the delivery room for various reasons. There might be crowded delivery rooms, etc. But having a relative along with the mother throughout has extensive benefits. So now, I thank you, Dr. Malik, for an excellent presentation, and we'll go ahead with Dr. Shwetal Bhatt on her presentation on the warm chain. So, Dr. Shwetal, the floor is yours. Please go ahead and please start your video. Thank you. Dr. Shwetal, you can go ahead and present, and please start your video so we can see you when you're presenting.
Am I audible, sir?
Yeah, you're audible.
Hello?
Please go ahead.
Okay. And my video?
You're audible. Please, can you make it
Are you
full
able
screen?
to see my presentation?
Yeah, but can you make it full screen? Can you make it full screen down?
Okay,
Yeah,
fine.
yeah, we can.
Thank you, sir.
Yeah, we can see.
So let's talk about the warm chain. What is the one? It's a series of interlinked simple steps which we can ensure by a teamwork. And the first step of our warm chain is, as already AIIMS sir has talked about the skin-to-skin contact. Before that, keeping the delivery room warm. Before the birth, we have to ensure that the delivery room is warm between 25 to 28 degrees centigrade. Especially in the winter months, we often see that the delivery room temperature is not maintained. And there is a lot of importance of delivery room temperature maintenance as for the baby as well as for the mother's comfort also. The skin-to-skin contact before the birth of the baby, we have to counsel the mother, as said. What we have seen our QI, that if we counsel the mother while the mother is waiting for the delivery, the acceptance of the team increases. Mother is always ready for the skin-to-skin contact, but while this counseling process, the team is ready for the skin-to-skin contact. And routine care, all the stable babies should be done routine care on mother's abdomen only. The next step, a warm resuscitation. Before the baby is delivered, we have to be ready with our resuscitation corner, where we have to have a switch on the warmer before 20 to 30 minutes of the delivery. That will ensure and keep all the resuscitation equipment ready, and the two warm towels under the warmer so that they are warm. And check for all the instruments, especially the bag and mask should be assembled before the delivery of the baby. It will take time if you assemble at the time of the delivery or when the baby is in the resuscitation corner. which is going to waste our golden seconds early first minute. Fourth and fifth is immediate drying. The importance of immediate drying is that as soon as the baby is out from the this amniotic fluid, there is a loss with the evaporation, which we have to prevent. And so immediately keeping the baby on mother's abdomen and applying a warm towel on the baby will help in prevention of the hypothermia. And as one of the participant has asked regarding the cap on the head, yes, 75% of the heat loss occurs from the head. And so in our delivery room, we keep ready. If we don't wait for the cap or anything, we have sterile gauze ready of square measuring that immediately they apply on the on the baby's head to prevent the heat loss from the scalp. We have already discussed much during our during last week about the plastic bag or a wrap in a baby is less than 32 weeks, which is very helpful and which is very important for prevention of the hypothermia. Immediately placing the baby in the plastic bag or a wrap or a cling wrap. Fifth is our exclusive breastfeeding. As already talked by Dr. Asim sir, immediate skin-to-skin contact and immediate breastfeeding is nowadays recommendation from the WHO. And immediate skin-to-skin contact and breast scroll helps in establishing the immediate breastfeeding, which is not only benefit to the baby as well as the mothers. Also, there is a benefit of decreasing postpartum hemorrhage, less pain. The studies have shown that if we keep the baby immediately on skin-to-skin contact and ensure breastfeeding within first hour, there are less chances of pain. There is the pain threshold of the mother is increased, and mother is able to bear the pain of episiotomy suturing if happening during the breastfeeding. In the cesarean section, as Dr. Asim has already discussed about that, if there is a motivated team, and each one has been allocated their role, it is very much possible to put immediately the baby. As in our unit, what we do is that immediately the baby is delivered, we keep the baby on mother's abdomen as well, because the lower segment cesarean section is going on. On table only, during the closure time, the baby is kept on mother's abdomen, and gradually the baby crawl towards the breast, and breastfeeding is ensured, which is when we have discussed with the mother, as it's a spinal anesthesia was there, the mother also felt very good, and the mother's apprehension about the survival of the baby as well as during the cesarean, mother's apprehension has decreased when the baby is kept immediately for the breastfeeding. And as sir said, it is all motivated team which is required, and there was a lot of resistance from the obstetrician in our unit, and even the nursing staff of the labor OT, where what we did is that we asked one of the nursing staff from the NICU who was specifically accompanying the pediatrician for just keeping the baby on mother's abdomen and ensuring the first feed on the table only. Postponing the bathing, we discussed during our week that all the babies postpone the bathing for for the full term baby more than 2 kg for 24 hours. And for low birth weight babies, we postpone no bathing in the hospital settings. And for the low birth weight babies, we counsel the parents for postponing till 7 days. And especially in the winter months, as such, also bathing twice a week is okay. And sponging can be ensured for cleaning the baby. Appropriate clothing of the baby is very much important, especially the cap, socks, and mittens. However, during the skin-to-skin contact, we apply only the cap. The hands and the legs are kept free, so that with that Wernicke's, we have seen that with Wernicke's caseosa on the baby, that is easy for the baby to crawl compared to the socks applied to the baby. So after the delivery, appropriate clothing, wrapping of the baby is very much important. But along with that, we have to also explain to the parents that there should not be wet nappy. So they frequently check for wet nappy and promptly remove the wet nappy. Keeping the baby with the mother, that is rooming in or bedding in, or keeping the baby with the mother, next to the mother is with a well covered clothing. This will help. This helps in better secretions also. What we have seen is that if we keep the baby with the mother, it helps in better secretions, better lactation management, as well as the warmth of the baby is ensured. And when the baby is in KMC, as warmth is ensured, especially when keeping the baby next to the mother. The risk of hypothermia, risk of even the risk of hypoglycemia are decreased. Warm transport incubators are if the baby needs to be transported to the other facility, there is a transport incubators should be used. If the transport incubators are not available, then what we have observed in Gujarat, we promote to our 108 transport team for a KMC transport, and that helps in prevention of hypothermia, as well as it decreases the morbidity of the babies. If the KMC transport, if the mother is very sick, we also encourage for the alternative KMC transport, like father can be accompanying or the grandparents can accompany the baby. But if they are also not available, not willing, proper wrapping of the baby is required during the transport. And in utero transport, when the facility is aware that this is a high risk pregnancies, and then this they will not be able to handle the newborn, which is high risk of the high risk pregnancy, it is better to early transport the baby in utero for better management. All these 10 steps can be ensured only by educating, training and workshop of all the team members for the skill development and capacity building for resuscitation, skin to skin contact, breastfeeding, using of equipments like radiant warmers and incubators. Such training should be done repeatedly, as on and off the new members in the SNCUs are added, and they should be trained, as well as the existing members of the team can get repeated CME will help to ensure this teamwork, and these 10 steps of warm chain can be ensured. So if we summarize, increased awareness and a series of simple measures are all that is needed for prevention of hypothermia in most of the neonates. And the prevention of hypothermia starts right before the birth in the delivery room, NICU and maternity ward, especially in this winter months. Before the baby is born, delivery room temperature we need to ensure. Skin to skin contact, rooming in, and prevention of hypothermia during the transport is the main points for ensuring the prevention of hypothermia. Thank you.
Thank you, Dr. Shwetal, for covering in short pretty much the points of the warm chain. There are a few interesting questions, and if you can answer some of them. One is Dr. Karthikeyan has asked, what is couplet care and when to advise bathing? So we'll take the bathing question later. And what do they mean by couplet care?
Ma'am, sir, exactly I don't know about the couplet care, but what I understand is that mother and baby duo should be kept together in a postnatal wards.
Okay, and so we kind of ensure that they remain together, and we ensure that they're both warm, etc. So we'll have opinions from others. Coming to the question on bathing, and that's something which is very interesting. So a few questions on bathing is when to advise bathing. You mentioned more than 24 hours, but after 24 hours you should bath. But whose recommendations are these? And second question, in your hospital, do you do bathing of the baby in hospital, and do you know of other places where they do it?
No, sir. Okay. We do not do bathing in our hospital, as well as in most of the hospitals in the government setups. Nowadays, bathing is not at all done. And for it is for the term, we discharge the term babies within 48 hours. After 48 hours, so we advise the parents to do the bathing in after 48 hours when they go to home. In the winter months, we don't advise for the bathing even after 48 hours. We see that we ask them that sponging is okay for the babies when the temperature, outside temperature is 4 to 12 degrees centigrade. It's not advisable to bathe the baby daily. Once in a week, they can have a bathing of the baby.
Okay, one is, I think one of the other participants, faculty members have said that couplet care is when you take care of both the baby and the mother by the same nurse or the same team. So this is Dr. Rita Bora who has answered that question. Coming to another question which is interesting is you talked about KMC transport. So one of the questions is how far can you transport a baby via KMC transport, like 10 kilometers, 20 kilometers? Are there any studies from India, or would you know about how useful it is?
So regarding the distance, I do not have any evidence or studies just now right on hand. But what babies coming to my facility in KMC transport from different, like we get from 2 hours distance or 3 hours distance in my, because my is a tertiary care center for the central Gujarat. We have seen that the outcome of the babies received in KMC transport, the top scoring is better compared to the babies who have not received in the KMC transport. And it is really a wonderful question for me. Definitely, I'll come out with the study and research for this question.
Good, thank you. Another question, and again, this is for skin-to-skin care. If the mother is critical, how to start skin-to-skin care contact just after birth? Now, the question doesn't say how critical and what is the meaning of critical, but you can probably explain from some of your experiences to in what critical patients you may start or you may not start. This is by Dr.
Sir,
Abhinanda.
if the mother is critical in form of mother's cardiorespiratory system is unstable, then we will not much encourage for the skin-to-skin contact. But like most of the, even we have done the skin-to-skin contact with the mothers with eclampsia mothers on myself. As the mothers in general anesthesia or in the spinal anesthesia, there is no interference of the mother at all. We have to just take care of the vitals, which anesthetist is already taking care of the vitals of the mother. And keeping the baby on skin of the mother is not going to disturb the mother's criticality. In fact, what I feel sometimes we should do this study that they may help in stabilizing the mother's vitals also.
Okay, so there is a study that was done, which we have published, which shows that doing kangaroo mother care, not in the delivery room, but in the NICU, does improve the mother's vitals and actually reduces the blood pressure to some extent. But it's not like a very good study, but there is some evidence for it.
Recently, sir, one of my baby, like mother was in eclampsia, so in OBS ICU, and as the baby was quite good and sucking well, I just asked the nursing staff to go and assist for the breastfeeding, and we found that mother's antihypertensive dosage requirement decreased in 24 hours. So that is one of the indirect indicator that breastfeeding helps in stress reducing and stabilization of the vitals of the mother. This is a single like case of last week only, but a series of case we can definitely do.
So we noted the same thing, but we have not been able to do a study. But it's a good, somebody wants to do a study. This topic is open
sir,
for
it's
you.
really a good question, and we should go ahead with this study. We have a big OBS ICU. In fact, we have more than 40 to 60% high risk deliveries.
Oh, that's good then. Dr. Nishant Bansal asks how to check the baby is not overcovered and overwarm, which is common in North India in the winter season. So basically, he's trying to say that how do we ensure that we do not end up causing hyperthermia for the baby by covering extensively. So your answer for that?
So this hypothermia can happen in the summer months, but in winter months it's with overcovering. We'll keep the face part open, so there is no question of overcovering the baby.
Okay. So one of the ways is probably teaching the parents to measure temperature by the skin touch method, so they would have an idea whether the baby is warm enough well, and that would ensure that the baby does not become overcovered in a way. So basically, we are looking at trying to prevent undercovering, but we do not want babies to go very high. It is very unlikely to happen if you are just covering with routine.
Sir, this too happens in summer months in like Baroda and Ahmedabad. It is quite hot. So we have to ensure in the summer months that there is no overcovering of the babies. But most of the time, parents are, even uneducated parents have awareness about the season and the clothing.
Okay, great. So last question before you go. This is from Dr. Sri Nandan Majumdar. Should we start giving skin-to-skin care before drying the baby, and also about the apprehension that the baby might fall from the mother's abdomen? The fall from the mother's abdomen, I think we can discuss because it does not happen because somebody is always there to take care of it. But the question is whether we should start skin-to-skin care before drying. So I did not.
Sir,
so
I would like to answer the first part also. Like there was a Dr. Nilima Raghavan came from the Stanford for one of the collaboration with Gujarat government, where she said that because if we keep the babies unattended, there are chances of fall, and they in there. So baby should not be unattended. At least one ASHA, one delivery accompanying, or one nursing staff is holding the baby. Then there is no question of falling of the baby, and mother's hand is also on the baby. Second is that as soon as the baby is born and there is a delayed optimum cord cutting is like followed, we keep the baby directly on mother's abdomen and we start drying from the back of the baby. Then like you can immediately, first you dry the scalp, immediately apply the cap, and then dry the other part of the body. So it's not necessary that fully dry the baby. First keep on the mother's abdomen. Start from the back, and then you just turn the to the from the prone to supine. Immediately dry. It's if I show the video, I think they will be able to appreciate it more. But I'll definitely try to take out the video and keep on the group.
Good, thank you. I think thank you, Dr. Shwetal, for an excellent discussion. We'll go to the next Dr. Rita Bora, and she'll be talking on modes of heat loss. Madam, can you share the screen and share your slides, please? Dr. Rita Bora, and we'll take the questions as they come later on. We can see your screen. Can you make it full screen?
Yeah.
Perfect. Please go ahead. We can hear you too. Please go ahead.
Yeah, thank you, organizers, for giving me this opportunity. So I'll be discussing regarding heat loss in newborn. So before we go to the topic, let us understand that when the baby is inside the mother's womb, the temperature is almost 38 degrees centigrade. And after delivery, therefore, the neonate is exposed to a cold environment in the labor room. And if we do not take proper care, there is almost 2 to 4 degrees centigrade loss in body temperature in the first 10 to 20 minutes, and there are further losses thereafter. So if it continues like this, the baby becomes hypothermic. And we also know that hypothermia increases neonatal mortality by 28%, which is quite a lot. Now, there are certain mechanisms by which the neonates produces heat. So one is metabolic processes, like the tissues in the body, especially in the brain, heart, and liver. It produces energy through metabolism of glucose, fat, and protein. And mostly glucose is the main metabolite. Then there can be voluntary muscle activity. So increased muscle activity during restlessness and crying generate heat. Conservation of heat is also done by flex posture, which is taken by the baby during cold exposure. There is also peripheral vasoconstriction. In response to cooling, there is vasoconstriction, which reduces blood flow to the skin and therefore decreases loss of heat from the skin surfaces. There is non-shivering thermogenesis. Now, heat is produced by metabolism of brown fat. We know that brown fat is there around the kidneys, the adrenal glands, head, neck, heart, great vessels, and axillary region, and around the scapula. This brown fat is deposited mostly in the last trimester, and so the preterm babies are deficient in that. Also, the IUGR babies are deficient in brown fat. The thermal receptors transmit impulses to the hypothalamus, and this stimulates the sympathetic nervous system and causes norepinephrine release in the brown fat. And this norepinephrine in brown fat activates the lipases, which results in lipolysis and fatty acid oxidation. And this finally leads to production of heat, which is released into the body rather than being stored as ATP. Now, we also need to understand regarding the optimal thermal environment. It is known that the environmental temperature, which is comfortable for adults, mostly around 24 degrees centigrade. This is very difficult for the neonates to maintain body temperature. This temperature is very cold for the newborn. Exposure of the newborn to a temperature around 23 degrees is almost like an exposure of an adult to 0 degrees centigrade. And smaller is the neonate, less is the tolerance for heat and cold. However, we have to understand that there is no single temperature which is ideal for all sizes of neonates, for all gestation or all conditions of the neonates. It would vary on whether the baby is healthy or is having sickness also. However, if in the labor room the baby is immediately dried put on skin-to-skin contact with the mother and is covered properly, which includes the covering of the head, as has been explained in the previous talks. The appropriate room temperature to keep the baby is around 25 to 28 degrees centigrade. So as we said before, the room temperature which is needed for different size babies is different. Like for a baby who's between 1 to 1.5 kg would need room temperature of around 30 to 33 degrees centigrade. Between 1.5 to 2 kgs, the baby would need a little bit higher temperature, lower temperature, 28 to 30 degrees centigrade. And when the baby is about 2 to 2.5 kg, baby would need 26 to 28 degrees centigrade. And this would also depend on the baby's sickness. Like if the baby has respiratory distress syndrome, sepsis, birth asphyxia, baby would need a higher temperature than a baby who's of same weight but with no problems. So having understood regarding the mechanism of heat production and the need of the environmental temperature and how the baby produces heat in the body during exposure to cold, let us understand what are the ways by which heat loss is there from the newborn. So the first method through which heat loss is there is conduction. So when we place a baby, a naked baby, especially on a cold surface, there would be heat loss from the baby towards the surface on which the baby is being kept. This is conductive heat loss. Then when the baby is being kept in a place where there is draft of air, the heat from the baby would be transported to the air, and this hot air would get removed and would be displaced by the cold air. So this is heat loss by convection. There is also evaporative heat loss when the baby is covered with liquid, like in the labor room when the baby is covered with amniotic fluid. There is evaporative heat loss because of evaporation of this amniotic fluid from the baby's body. It is also seen that babies would lose heat from the body through radiation. When the baby is in a room where there are cold substances than the baby's body, then heat would be lost from the baby towards these objects, although the baby is not in direct contact with the objects. So little bit elaboration regarding these methods of heat loss. So evaporative heat loss is the greatest source of heat loss in the labor room. And it can be insensible heat loss from skin or through breathing, or it can be sensible when the baby is overheated, and then it can lead to sweating. It is the most important method of heat loss in the labor room because at this time the skin is covered with amniotic fluid, and if proper care is not being taken, if the baby is not dried immediately, with the evaporation of the amniotic fluid, the baby would also lose heat. And with each gram of fluid loss, there will be loss of around 0.6 kilocalorie heat loss from the neonate. Factors that influence evaporative heat loss are air velocity, vapor pressure, and infant's body surface area. So putting preterm neonates in cling wraps or bags prevent evaporative heat loss. Now the next is conductive heat loss. It occurs when the neonate is placed on a cold surface, table or weighing scale, cold bed, etc. And it is influenced by the size of the surface area in contact as well as the temperature gradient between the surfaces. Convective heat losses occur when the baby is exposed to cool room air or draft of air. So if the baby is being kept in a place where there is draft of air because of opening of doors or windows, or then the chances for convective heat loss is most. Surface area, airflow, and also temperature gradient between the surfaces. Now, another very important method of heat loss in the labor room is radiative heat loss, and it is said that it is one of the greatest source of heat loss in the labor room. When near a cool surface, without being in direct contact, the heat loss can occur through radiation, and factors influencing radiative heat loss are temperature gradient between two surfaces, surface area of solid surfaces, and also the distance between the two surfaces. So once the heat loss is there, then the baby might develop hypothermia. So if it is in the range of 36.5 to 36. This is cold stress. This we all know. And between 36 to 32, it is moderate hypothermia. And then when it is below 32 degree, it is severe hypothermia. Cold stress is a cause for concern, but when it is below 36 degrees centigrade, it is a danger sign. We need to warm the baby immediately. And when the baby is having temperature below 32 degree, the outlook becomes grave and skilled care is urgently needed. Now, effects of heat loss and hypothermia in neonates has already been discussed in the first lecture, but still I'll just go through it for recapitulation. So, when the baby is exposed to air, there is activation of non-shivering thermogenesis. There is metabolism of the brown fat. There is increased consumption of oxygen, increased respiratory rate. There is pulmonary vasoconstriction, which can lead to PPHN. There is tissue hypoxia, peripheral vasoconstriction. There is anaerobic metabolism, leading to metabolic acidosis. Also, there is hypoglycemia because of depletion of the glycogen store because of increased use of glucose for energy. So, how the baby manifests? There will be acrocyanosis and cool mottled or pale skin. There will be hypoglycemia. There can be hyperglycemia also transiently. There can be bradycardia, tachypnea, restlessness, shallow and irregular respirations, respiratory distress, apnea, hypoxia, metabolic acidosis, decreased activity, lethargy, hypotonia. There can be feeble cry, poor feeding, and decreased weight gain. So many times we do see babies who are being brought to the hospital, especially during these winter months, and the mother says that the baby becomes very cranky in the morning time and then doesn't take feeds properly. So we need to exclude cold stress also in these babies. So we need to teach the mothers that babies may become cold because of because most of it in the morning times, and if the baby is not being clothed properly and the baby is lying on wet nappies, baby may suffer from cold stress, and the reason for not taking adequate feeds or becoming lethargic may be cold exposure. So which are the babies who need monitoring for heat loss? So ideally all babies need to be monitored. We need to teach all parents when they go home regarding monitoring for hypothermia. That can be taught by teaching them the touch method, like they need to touch on the abdomen as well as compare the temperature with the sole. And if they find that the soles are cold, they know that baby is in cold stress. So that method needs to be taught to each and every mother, because we do not expect that all parents would be having a thermometer at home, and many times they might bring the baby with hypothermia because of lack of knowledge of hypothermia being present, and also lack of knowledge of keeping the baby warm. So these things must be taught to the parents. Now, apart from teaching all mothers, special care has to be taken to monitor heat loss in babies who have low birth weight, or who are ill, or who had required resuscitation at birth, or who are at suspicion for hypothermia or hypothermia with rewarming or cooling down, or if the newborn has been readmitted to hospital for any reason. Now, the 10 steps of warm chain for prevention of hypothermia has already been explained, so I'm not going into the details, but just to mention the steps. So we need to have a warm delivery room where we need to have the appropriate temperature, and all the equipments need to be kept in proper temperature. Immediate drying has to be done. Skin to skin contact needs to be done. So in details, everything has been explained before. Breastfeeding is very important because that prevents hypothermia as well as maintains the baby's glucose level, avoiding hypoglycemia. And we need to postpone weighing and bathing. There was one question who had asked regarding weighing, when should we go for weighing of a baby after birth. So we need to understand that weighing is not an emergency, so it can be delayed up to 6 hours. There will be no change in the birth weight. So once the baby is stable with the vitals after being kept in skin to skin contact with the mother, then we can go for weighing of the baby. So there is no hurry in taking weight. And also the vitamin K can be given when the baby is on the skin to skin contact with the mother. We need to clothe the baby appropriately many a times parents swaddle the babies so much that there is no layer of air around the baby and the cloth. So that we have to make them understand that there should be a layer of air between the clothing and the baby, so that the baby can breathe properly. So that the heat loss from the baby is less. We need to keep the mother and newborn together. Warm transportation as well. Take extra care that the baby doesn't get exposed to cold room or cold temperature. That needs to be taken care. As well as training and raising awareness in the health workers is very important. So the key messages are: neonates are prone to heat loss during delivery and in the postnatal days. Heat loss occurs through conduction, convection, radiation, and evaporation. Hypothermia increases mortality by 28%. So this is quite a significant rate. So we need to take care that babies do not become hypothermic in the labor room as well as in the postnatal wards or inside our NICUs, and prevent. Thank you for your patient hearing.
Thank you, Dr. Rita Bora, for doing a good summary of the chains and the modes of heat loss. I will just ask you one question and then we can move to the next speaker. Now, the question is this. As you mentioned, 23 degrees of adults is equal to 0 degrees of newborn is what you mentioned. So the question that has been asked is how much, by Agita Sharma, is how much of 25 to 28 degrees of labor room will translate to a baby's temperature. I'm not sure about the answer, but if you know, it would be good.
Actually, there is no mention of that. The comparative temperature in the labor room of 25, what would be that exposure if we compare that with 0 degree and 23 degree? So there is no answer to that as such. But it has been found that if it is 25 to 28 degrees centigrade, the babies usually are comfortable without excessive metabolism and without excessive risk for hypothermia. So
Dr. Nisha,
at the same time, we need to take care of covering the baby properly after having removed the amniotic fluid properly. So appropriate drying, covering, all that has to be done along with skin-to-skin contact. So if we do all this and maintaining the room temperature, the babies are at lowest risk for hypothermia.
So Dr. Nishant Bansal has a question related to that. Since we say temperature should be 25 to 28 degrees in the room, how can parents know the temperature in the room when they're at home? I don't think it is in the hospital if they don't have room thermometer. So again, question might not.
Like.
Yeah. So how do parents have an idea of the room temperature? So Dr. Umesh Khurana has probably answered, and it says that we have digital room clocks available with display of environmental temperature. So it is probably, if people have access to technology, then they will be able to do it. But if there is no access to technology, then it might be difficult. Then the best way to know is to look at, as you mentioned during your talk, measuring the baby's temperature by hand method, using touching the forehead and the chest and the peripheral limbs and making sure that the baby is warm. That might be the only way to ensure that the baby remains warm, and it might be difficult to know the room temperature if you don't have access to maybe apps or digital clocks, etc. Thank you, Dr. Rita Bora. I think since we are running short of time, we will go to the next speaker. Now we have Dr. Kavita from Goa, who will be speaking on radiant warmer and incubator care. Dr. Kavita, can you please share the slides and we can... Yeah, we can see the slides. Can you go to full screen from the first slide onwards and then start presenting? Yeah,
So, is it okay now? Yeah.
It's okay. You can go ahead. We can. Yeah, go ahead.
Yes, sir.
Thank you.
So, I'm going to speak about radiant warmers and incubator care. So we'll just about radiant warmer, we'll briefly see the parts, the functioning and settings, and how do we clean and disinfect, and some few troubleshooting points. So like we all have seen during our last week of when we shared all the materials and studied about these equipment. So in a radiant warmer, we have a heater assembly. So here is the heater assembly. Then you have a control panel. You have the bassinet where you mount, and this is the mount. Sometimes there are drawers in this mount for storage. And some of the warmers have additional CPAP equipment attached. There is an X-ray plate which is also under the bassinet. Sometimes there is resuscitation equipment also attached to the warmers, and also an inline weighing scale. The heater assembly is it has a heating rod and it has a parabolic reflector. So the heating rod is the principle is that it heats the baby by radiation. That is a heating source which is not in contact with the baby, and the reflectors allow the heat to be distributed throughout the in the environment of the baby. In the control panel, we can select first of all the mode. So which mode we want to put the warmer in. We can select how much heater output we want. So here are the heater output buttons where we can increase or decrease the heater output. There is an alarm silence button. On the display, when you see the display on the control panel, you can see the patient's temperature. You can see the set temperature that we set. We can see the heater output on the warmer. And there are also various alarms which are displayed depending on the different types of warmers. Different types of alarms are displayed on the control panel. Okay, now there was a little bit of a lot of questions asked on the platform regarding these modes. So there are three different modes that we encounter in that we see in warmers. So first mode is a servo mode or a baby mode. It is also known as a skin mode, the skin mode. So here the heater output is regulated by the skin temperature. So like we discussed on the Telegram platform, it is a feedback mechanism. So the skin probe is attached to the baby, and whatever is the temperature of the baby is checked. And depending upon the set temperature, the heater output is either decreased or increased depending on the temperature of the baby. So this is the servo control mode. This is the most common mode that we use when we do open care of the newborn. This is the manual mode. Now, if you can see in the manual mode, there is only one probe here. So there is only a skin probe and the manual mode. So you have a servo mode and manual mode on this particular warmer. Here what we do in manual mode is that we adjust the heater output manually. So there is no temperature set as such. You can increase the heater output or you can decrease the heater output. Now this heater output, how will you decide? Depending upon the temperature of the baby that you are checking manually. So you take a digital thermometer and check the temperature of the baby. If you find the temperature is less than what we want it to be, that is less than 36.5, then you will increase the heater output manually. If the temperature is high, then you will decrease the heater output manually. So it is not servo control. So you need to manually check the temperature and then adjust the heater output. Now this manual mode is basically used during resuscitation, that is before the baby is born. So when we want to preheat the mattress, preheat the sheets, we put the warmer on the manual mode with 100% heater output so that the sheets and the mattress gets preheated. This is done approximately 20 to 30 minutes prior to the baby being born. Also in the SNCU or in the NICU, when we get intimation that the baby is delivered and is going to be transported inside our NICU, again then also we have to put the warmer on, put on manual mode and increase the heater output so that the warmer is preheated. Then suppose a baby has hyperthermia. So in that scenario also we can change the mode to manual mode and decrease the heater output so that the baby's temperature comes down. Once the baby temperature comes below 37.5, then we will switch to servo control mode. Same thing for low temperatures. If you have babies with low temperature who come to you, like severe hypothermia or less than 34 degrees Celsius, you would keep the heater output, increase the heater output manually, keep on manual mode. Once the temperature comes up to 34, then you will shift to servo and then increase the temperature gradually. So that is the manual mode. Now this is what you can see here in the third panel is the air mode. So now this particular warmer which is shown here is having only a skin mode and an air mode. It does not have a manual mode. So here you can see there are two probes here down. One is the skin probe and one is the air probe. Now, if you're keeping the warmer in air mode, then you need to keep attach the air probe to one of the side panels, or you can attach to the control panel. Now this will detect the temperature of the air around the baby under the warmer. Whereas this is the skin probe, which will check the temperature of the baby when the skin probe is attached to the baby. So here you see there is no manual mode, there is only skin mode and air mode. Now if you have this kind of a warmer and you do not have manual mode, how would you do prior to resuscitation? How would you do preheating? That is, you keep in air mode before the baby is born and set the temperature at 34 degrees Celsius. So this is how you do preheating when you do not have a manual mode on your warmer. And there are some warmers like this, the first one here, which has got all three modes. So you have a skin mode, air mode, and a manual mode. Okay. Now coming to setting. So how do you put the warmer? So you have to first put the warmer on. Remember to preheat. So switch on the warmer 20 to 30 minutes before the baby is received. In this scenario, manual mode at 100% heater output or air mode at 34 degrees Celsius. Once the baby is stabilized, is kept inside the warmer, received inside the warmer, then you attach the skin probe to the baby's skin and you set the servo mode temperature at 36.5. So normal temperature of a newborn is 36.5 to 37.5. So you would like to not have very high temperature. So 36.5 degrees is a good temperature setting to set on a servo control mode for warmer, or even for that matter for an incubator. Now if you're keeping the warmer on air mode, like a scenario like you have two babies, so we do not recommend sharing of warmers, but if you have twins and you want to, there is overcrowding, you want to share a warmer, like we discussed when we had discussions, in that scenario we would keep it on the air mode because we don't have two probes to check temperature of both the babies. So you would keep on the air mode, and the temperature that you set on the air mode varies with the weight of the baby and the gestational weight of the baby and the day of life of the baby. So these are the temperatures that you set on an air mode. All right. So I hope this is clear. So this is the temperatures you will set on the air mode. Generally, if a single baby is being cared for in open care, then you keep it on servo mode and set the temperature at 36.5 degrees Celsius. So this is how we will set the temperature. So preheat, once the baby comes, attach the skin probe and then change it to servo control mode. So these are some, this is just to indicate about the heater output. Now these are, there were some questions as to what is actually the meaning of servo control. So servo control is where the heater output is regulated by the baby's temperature. So in this first panel, like you can see, the skin temperature of the baby is 37.5. So it is going on the upper limit. Your set temperature here is kept 36.2, which is kept on the lower side. Maybe it's a special circumstance. But if the temperature of the baby varies from the set temperature by 0.5 degrees, then one is an alarm will come, and second, the heater output here has completely become zero. So this is how the heater output will get regulated in a servo control mode. When the temperature of the baby is more than the temperature which is set, then the heater output becomes zero. At the same time here, if the temperature of the baby is very low from the set temperature, then the heater output becomes maximum. So this is how the servo control warmer mode will work when you're checking temperature of the baby. So a lot of discussion also had happened on probe attachments. So this particular study which is mentioned here has had compared the temperature which was measured by the probe when the probe was attached to various parts of the body. So they attached to the right hypochondrium, they attached to the forehead, they had attached to the foot, the sole of the baby. And when they correlated with digital thermometer readings, they found that when the probe was attached to the right upper hypochondrium, that correlated best with digital thermometer, that had the best correlation. Now the rationale behind attaching a probe on the site of right upper hypochondrium is that the underlying liver is well perfused and it will give a better reading of the temperature of the baby. So we should not attach the probe to bony prominences. The best place to attach is the right upper hypochondrium. So we attach like this. We take a long tape, a longitudinal tape, we slit here, and then we attach in parts of 1 inch, 1 inch, 1 inch. So it's a 3-inch tape. If the baby is very small, of course, you will have to make a smaller size tape. But this is how we would attach so that even the connection or the junction between the probe and the wires is also protected. Here, this is another way of attachment where you can make a square and then attach. Here, tegaderm is used. You can also put tegaderm if the baby is an extreme preterm to protect the skin of the baby. Tegaderm is first attached to the skin. The probe is then attached on top of the tegaderm, and then the probe is fixed. Yes, the probe will measure even if you attach the tegaderm to the skin. Here also you can see that the baby tegaderm is, the probe is attached with the help of a tegaderm. That is the transparent dressing. Any dressing which sticks well to the skin is going to attach the probe. No matter what type of dressing you use, you cannot not monitor whether the probe is displaced or not. Probe position, whether it is attached properly to the skin, whether it is apposed to the skin, has to be monitored regularly. This was another question which was asked, whether we can clothe the baby and keep under the radiant warmer. Now, if the baby is stable, we could cover the baby with or swaddle the baby and still keep on the radiant warmer under servo control mode. But if the baby is very small, if the baby is unstable, you need to monitor the respirations or the perfusion of the baby. It is better to keep the baby, at least the chest and the abdomen of the baby, exposed for monitoring. We do put caps, socks and mittens for a baby under, and diaper for a baby under warmer. We also continue nesting under warmer. So nesting is continued, socks, mittens, caps are put, and probe is attached on the right hypochondrium. If the baby is nursed in prone position, we have to attach the probe either to the loins or the flanks. Remember to monitor for displacement regularly. About cling wrap with warmers. So these are the various techniques we can use when we are caring for babies and we want to cover the babies with cling wrap when they are under warmer care. So we can cover the full warmer like this with a cling wrap sheet above, or we can wrap the baby itself like how we do in the delivery room. We can wrap the baby and then bring the baby on top. Once the baby is to the SNCU, we can cover the warmer with a cling wrap like this. This also prevents insensible water losses and helps to maintain temperature of extreme preterms better. So knowing how we set and how we attach the probes, we need to also see that the equipment is cleaned regularly. This was shown in the videos in the materials. So when the baby is not under warmer, we have to clean with 2% glutaraldehyde. When the baby is in the warmer, then we have to clean daily with a cloth dampened with soap water. In our unit, when we do the mattress in the bedding in the morning, we lift the baby and we clean the undersurface with 2% glutaraldehyde just to ensure proper disinfection. Once the baby gets discharged, in between babies, a thorough cleaning with 2% glutaraldehyde has to be done every time the baby is changed from, or baby is discharged, or another baby is being put in the warmer. So when about radiant warmer, points to remember: if the baby is in manual mode, remember that the probe there is no probe monitoring the baby's temperature. So we need to manually check the baby's temperature every 15 to 30 minutes. You cannot not monitor the baby when the baby is in manual mode, because we have to manually adjust the heater output. Temperature should be monitored manually at least 6 hourly, irrespective of what mode you have kept the baby in, air mode or servo control mode. You still have to monitor temperature. Be very aware of the probe getting displaced, because this is one of the most common causes of hyperthermia in our units, where probe gets displaced or it is not properly apposed to the skin, and the baby, it will sense low temperature and heater output will increase. So you need to check the probe position. We should not use spirit to clean the side panels or the digital the control panels of the warmer. And this is one thing that we forget. We clean the warmers, but we do not clean the probes. So we have to clean the probes as well with isopropyl alcohol every day when we are doing the disinfection with the baby. So that was about radiant warmers. Now coming to neonatal incubators. The parts, so we have a canopy here. This canopy can be double walled or single walled. If it's a double walled, then it also prevents heat loss by radiation. So it improves or decreases the insensible water losses, but there is no long-term outcome as such difference noted. But when you have a double wall, the insensible water losses are reduced compared to a single wall. Then you have a humidity measuring equipment. You have the digital panel here where you can, again, same panels, the servo control mode and air mode is displayed and temperatures are displayed. Most of the incubators have additional things like they have inline weighing scales, they have inline cassette, X-ray cassette placement plate. And the biggest advantage of an incubator is that you can adjust the humidity inside the incubator. So we know that humidity, high humidity is needed to prevent evaporative losses from the baby. And an extreme preterm or a preterm baby has maximum heat loss because of evaporation. So then that will get prevented when you control the humidity around the baby. So that is the major advantage of having a closed care or an incubator care for a baby. So this is how we set an incubator. So again, before the baby is brought in, we can keep the incubator in the air mode and keep it at 34 degrees Celsius so that the air inside gets heated up. Once the baby is put inside the incubator, stabilization is done. Then you attach the skin probe and you set it 36.5 or up to 37.5. So 36.5 to 37.5. If you're setting the incubator in the air mode, then again you need to see these charts. Depending on the weight and the day of life, you will adjust the air temperature set that you set on the incubator. Again, if you're keeping the incubator open for a long time, like for prolonged procedures, etc., it is better to shift to air mode rather than keep under servo control mode. Humidity, initially we need to keep around 70-75% in the first few days because the heat loss is maximum that time, and then subsequently we can reduce it to 60%. So we need to check the water levels to maintain proper humidity in an incubator. And this is how you will see a visual panel which is similar to the warmer. You will see the set temperature, you will see the baby's temperature, you will see the air temperature and humidity. Some of the incubators also have oxygen. They can give oxygen to the baby, so that saturation is also monitored in some of the incubators. So this is how you will set when the baby is, when you want to plan care for the baby. This is one of the newer system, the hybrid system, where we can have open care as well as closed care. So the same machine is an incubator, and then with one button it opens up to the warmer care. So it heats up by radiation as well. It has got a heating mechanism here, plus it has got a convection mechanism under. So it works as a incubator as well as a warmer. So this is one of the new systems that we have to use. These are the transport incubators. So you can either have transport incubators with or without ventilators attached, without oxygen, air, etc. So this is they are smaller than routine incubators because they can help to transport babies intra-hospital or inter-hospital. This is the most ideal way of transporting, if at all you cannot transport in utero, because this will maintain temperature. Again, in this mode, you will maintain on servo control or air control. So again, two modes are available in transport incubator. Cleaning is similar. From outside, if it is occupied, we will use cloth which is dampened with soap water. Not occupied, 2% glutaraldehyde. In between babies, you have to do a detailed and thorough cleaning. So you need to actually remove the baby bed out. You need to remove the humidifier tray out. All those things have to be dismantled. So initial few times you might have to call the engineer or the service person to learn how to actually dismantle and clean the incubator properly. Remember to please check the water level in the humidity tray. Otherwise, the humidity will not be maintained, and your baby's temperature is also not going to get maintained. There were some questions on phototherapy. So when we give phototherapy under radiant warmer, please see that the phototherapy is tilted, because if you keep it flat under the heat source, then the heat source is going to heat up the phototherapy, and the baby's temperatures are not going to be stable. So we need to tilt the phototherapy machine and give to the phototherapy to the baby. In an incubator, you can keep the phototherapy above the canopy, so it will have effective phototherapy to the baby. So when we use incubator, a few points besides all the other monitoring that we need. Again, probe position has to be monitored frequently when the baby is in the incubator. Again, baby's temperature also has to be monitored manually, irrespective of what mode it is. Humidity, water levels have to be checked, because humidity is an important factor in an incubator when we want to control temperature. Thank you.
Thank you, Dr. Kavita, for and we look forward to answering a few questions. So one of the questions that has been asked, and it came from Dr. Umesh Khurana. He's talked about convecting warmers are better than rod warmers. So you have any opinion on this different kind of warmers?
So all radiant warmers heat by radiation itself. So convective warmers, I think he's talking about the incubator hybrid systems. I'm not sure. Because incubators will heat by convection and radiant warmers will heat by radiation. Right. I'm not aware of convective warmers.
Sure. Thank you. And the question about measuring temperature. How much time should the thermometer be placed in the axillary area until it beeps, or 2 to 5 minutes? And I think the person, Dr. Rutvi Trivedi, is talking about poster telling about 5 minutes. So I assume that she's talking about the mercury thermometers, where it was initially recommended 3 to 5 minutes. So can you comment on mercury thermometers, digital thermometers, and how to measure? And before
so mercury thermometer you have to keep for a minimum of 3 minutes if you want to measure. Digital thermometers are that it beeps when the temperature is it doesn't make a difference. So 3 minutes for a mercury thermometer is minimum that you need to keep.
So one of the things that has happened over the last maybe a decade or so is that Ministry of Environment has suggested that we should not be using mercury in thermometers, and most of us have shifted to digital thermometers. So that is one. So the question for that answer would be probably beeping at the end of putting the temperature. More important, what I wanted to ask related to radiant warmers. And over a period of time, they do have issues in terms of wear and tear, and they stop working. So how do you monitor, how do you check whether a radiant warmer is working properly or not? And what happens then? How do you go about managing issues when they stop working or they
Yes, sir. So the radiant warmers, any equipment for that matter, all equipment should be under annual maintenance contract. So we have our company person coming and doing an annual maintenance or preventive maintenance at least 3 times a year. Besides that, sir, every year we have a third party coming and doing calibration for our equipment. So we calibrate the temperatures for the air mode as well as the servo control mode. That is one. Besides that, handling, so no rough handling. The probes have to be checked. If the wires are loose or the probes are not picking up, those daily issues, those are handled immediately. So we call the service engineer or a biomedical engineer to sort out those issues as and when they come. But an annual maintenance and a calibration of these equipments is needed to see that they're checking temperatures properly and functioning properly.
Yeah, so that's a very important point, because buying an equipment and using the same without calibrating or checking it on regular basis is not really good, because as you mentioned, babies can get hypothermia if hyperthermia if the measurements are not accurate, and that is one of the commonest things that can happen. So it's important to take good care of the radiant warmers that are available with you. There are a few more questions, and let me see if this one. Okay, so what should be the ideal temperature in the NICU? Since we were talking about warmers, etc. In the NICU, any idea what might be the ideal temperature?
So 26 to 28 degrees Celsius we have to maintain, because for that, I think even for the equipment to function properly, environmental temperature should be that much. If it is very low, then the equipment itself will fail, plus the baby's temperature will not get maintained. So we need to have a thermometer and a humidity meter also inside our NICU to check for the temperature. So we maintain 26 to 28 degrees Celsius.
Great. We will stop here because we have just 20 minutes left before we reach 1 o'clock, and we can go to the next speaker, Dr. Mala Kumar, who would be speaking on management flowchart for hypothermia. Thank you, Kavita, for the wonderful briefing, and we go forward to Dr. Mala Kumar now. Dr. Mala, your presentation I think is being run by Dr. Pratima Anand, and you can please unmute yourself and put on your video and can start speaking.
Yes. Good morning to everyone, and I'm going to talk about management of hypothermia now. So the first step is to try to find a cause for hypothermia. If a baby is hypothermic, we have to find a cause. The cause may be a simple thing like a cold room, wet linen, wet clothes, or maybe an infection. Then we have to classify hypothermia. Is it mild, moderate, or severe? Then the management will depend upon the severity of the hypothermia. So if hypothermia is mild, that is the temperature of the baby is between 36.4 to 36 degrees centigrade, we'll first of all have to look at the room temperature. It must be between 25 and 28 degrees. We have to remove all wet clothing from the baby, and we have to provide skin to skin care. Mild hypothermia can be taken care of by just providing skin to skin care to the baby. We will be covering the head. We will be covering make the baby wear socks and mittens, but we'll keep the baby in skin to skin care. And we must remember to continue breastfeeding and measure blood sugar levels in the baby to rule out any hypoglycemia. It's very important to measure the temperature of the baby after an hour of skin to skin care so as to see whether it's actually helping or not, or has the baby's temperature fallen down further. Supposing after an hour we find that the baby is no longer in cold stress, then we can't forget about the baby. We must remember to continue care, which would mean continue skin to skin care, continue breastfeeding the baby, continue removing any wet clothing, and continue monitoring the temperature of the baby. At least 2 hourly in the beginning, and then 4 hourly, and then 6 hourly. Next, please. Next slide, please. Next slide, please, Pratima.
Yeah, next slide is there. Next, I think.
Yes, moderate hypothermia. So if the baby's temperature is between 35.9 to 32 degrees centigrade, we label that as moderate hypothermia. So with moderate hypothermia, just skin to skin care is not going to be, may not be sufficient. So the best thing to do is to put the baby under radiant warmer, remove any wet clothes from the baby, remove all clothes from the baby, and put the baby under the radiant warmer in servo control mode. Keep room temperature between 25 and 28 degrees. Remove wet clothing, we've said that before, and continue breastfeeding in between. Measure the blood sugar levels. If the baby is hypoglycemic, we have to treat accordingly. When the baby has moderate hypothermia and is put under the radiant warmer, it is important to measure the temperature of the baby every 15 minutes. It's also important to ensure that the thermistor is properly placed over the baby's abdomen, because if the thermistor is dislodged from its place, we'll not be able to measure the temperature properly. Then again, we will continue keeping the baby under the radiant warmer, and when he becomes normothermic, then also we have to continue monitoring his temperature, continue breastfeeding him, continue monitoring his blood sugar levels, and not just forget about him. So we have to continue measuring his temperature for the next 24 hours or even more. Next, please.
Is the slide visible, ma'am?
Yes.
Severe hypothermia?
No, severe is not visible, Pratibha.
I have moved it. Okay.
It's not showing. Not projecting.
Not showing as it. Severe is not showing it.
Okay.
So if the baby's temperature is less than 32 degrees centigrade, this is really an emergency situation, because the baby's prognosis will be very poor if we don't take care of his hypothermia. These babies must be put under the radiant warmer, and they should be put in the manual mode initially. We've heard a lot about how babies are kept in the manual mode, how they are monitored, and when for rapid warming, till the baby's temperature is 34 degrees centigrade. Remember, we'll have to measure the temperature of the baby by an auxiliary thermometer as well. These babies will require additional oxygen. They will have to be on a monitor so that we know their SpO2 and their heart rates. Oxygen will be required for the excessive metabolism of brown fat that will be happening in these babies. They will need IV fluids and frequent monitoring of the blood sugar levels. If there is hypoglycemia, that will have to be treated promptly. Monitoring of these babies will be monitoring all the vitals and also chiefly temperature, which will have to be measured every 15 minutes. If the baby shows no improvement, then antibiotics will have to be added empirically, and after taking cultures and the sepsis curve. Then care will have to continue beyond 34 degrees centigrade under server control, under the radiant warmer, and temperature of the baby will again have to be monitored every 1 hourly, and even when the baby becomes euthermic, temperature will have to be monitored every 2 hourly for the initial few hours, and then every 6 hourly, and we'll try to find the cause of the hypothermia. Thank you.
Thank you, Dr. Balakumar, for discussing the management of hypothermia. And I look forward to answering a particular question that was asked earlier.
Yes.
And this is related to fast rewarming or slow rewarming. If a baby has come from outside with a temperature of, and you measured that baby is 33 degrees centigrade, what should be the warming protocol? Is it slow warming, rewarming, or is it fast rewarming? Are there any advantages for both of them, or either is okay?
I think if the baby's temperature is not below 32, that is, if he doesn't have severe hypothermia, it's fair enough to keep him under the servo control mode of warming, and which would be slow warming. But the baby's temperature would increase by at least 0.5 degrees every hour, even under slow warming. Because rapid warming may be associated with a few problems like an intraventricular hemorrhage, for example. So we don't want to warm all babies rapidly, except those who've got severe hypothermia.
Right. Good. Thank you. So another question is, and this is observation from my part, and I would suggest maybe even other faculty members can share their experiences. Like in rural Gujarat, what happens is many of the babies who are born, clothing is not brought by the family members for at least 2 to 3 days, because apparently the clothing of the baby, new clothing for the baby, should be brought by the aunt of the baby, and the aunt may take 2 to 3 days to come. And hence, oftentimes, babies in the postnatal ward don't have any clothing at all, and they're probably wrapped by a sari or something which is very thin. So maybe, do you have any experience to share about what happens in your settings? Or maybe even other faculty members can share first. Maybe first you go ahead.
Even in our setting, this thing happens. But we try to tell these parents and mothers from beforehand that we will need clothes for the babies. So then the other problem is that they go to the market and buy clothes, and they are unwashed and not sterile. So to use those clothes becomes a problem. So if the mothers are already there admitted for inborn babies, they are admitted in the gynae ward, obs and gynae wards, then they are asked to get the clothes from before, wash them and dry them in the sun, and then we use those clothes. But if we don't have anything, then we use cotton wool rolls sometimes, then the baby is wrapped in sheets that they bring from home. Those for babies who are in the postnatal ward.
Great. So another question by Dr. Bhavan. Yeah, Dr.
Sir,
Shweta, is that correct?
Sir, we promote NGOs to supply baby kits, which includes the clothes and the caps and mittens, as well as the sweaters also, because this practice in Gujarat is like it's a traditional practice. So to overcome that, we have started with NGO support.
Great. That's very nice. So our hospital is a private hospital and like a charitable hospital, and we kind of give them new clothes straight away, and it is kind of at a very low cost. So and it helps. Dr. Mala, there's a question related to your presentation. Dr. Bhavana Gupta asks, what is the role of antibiotics in non-improving hypothermia, and why hypothermic baby is prone for sepsis?
No, one of the causes for severe hypothermia could be sepsis. So if sepsis is the cause, we'll not wait. Matlab, if a baby is having severe hypothermia, which is not improving despite all the efforts that we've already made, taken care of the sugars, taken care of putting the baby under the radiant warmer for rapid warming, and still if the baby's condition is not improving, we will not wait and waste time. Just giving a shot of antibiotics, beginning with it, may help the baby, because if he's having sepsis and he has severe hypothermia, then his prognosis becomes very bad. We've seen those figures in some of the presentations that were shown earlier. That's why. But we must remember to draw samples for cultures before we give the dose of antibiotics.
Thank you very much. So now what I will do, because we have a few questions pending and we have hardly about 10 minutes left. So we'll have kind of a rapid fire round, and I will just call out the name of the faculty. Maybe all the faculty members can put on their mics and their videos. So we don't spend time in putting the audios and on. And I will maybe ask questions rapidly, and please keep your answers to a bare minimum of maybe 1 or 2 lines. Also, there's a message from Dr. Devrari that everyone needs to take their quiz, because we're going to be starting the week 2 from tomorrow onwards. And so please, all the delegates, kindly ensure that you do take the quiz as soon as possible. So we will now have a rapid fire round. And Dr. Malika has actually asked a question and answered it herself. And it was also answered in Dr. Mala's presentation. Hypothermia is mainly because of external factors, such as hypothermia is because of external factors, and we must address the causes first. Someone had asked a question, if the baby is hypothermic, can we give skin to skin care? Dr. Malik?
Yeah, see, if the baby is hyperthermic, yeah, you can give the skin-to-skin contact, no harm, because mother has a accommodation system. So if the baby's temperature is more, the mother will cool the baby automatically, or if the baby's temperature is low, mother will increase the temperature also. So you can do that.
Yeah, excellent. So there is actual research papers which have what Dr. Asim Malik has said. There are publications which show that the mother's temperature can drop if the baby has hypothermia, and giving to skin care actually can be useful in ensuring normalization of the baby's temperature. So why antibiotics are not recommended in hyperthermia? Dr. Mala, can you take this question? Dr. Narsimha has asked this question.
Antipyretics, usually paracetamol, it can be given to a neonate who has fever, but the problem is that it acts by it acts by inhibiting prostaglandin production. So if prostaglandins are not produced, then the baby's response to that illness is not going to show. So if we will mask the baby's illness by giving paracetamol, it may delay proper treatment for the baby. So that's why it's not given. Usually you try to find the cause, but there is no harm in giving paracetamol in regulated doses.
Thank you. Dr. Amit Gul has asked a question. I don't think we can answer it straight away. He asked whether suggest some company or dealer supplying good quality room temperature thermometer. NNF has actually published a book quite some time back, and I think probably we need to publish more recent ones, where a lot of equipment used in neonatal areas were looked at and recommendations were made. but probably it's time to revisit and maybe have another book with respect to the equipment that is available in the neonatal space. So we will skip that question. So now Dr. Ruti Trivedi has asked, and I think Dr. Kavita can answer. In case of DC, and I think she's talking about death, warmer should be cleaned with same or something else. Dr. Ruti Trivedi has asked a question. Suppose the patient dies and the warmer, so what happens? That's what I'm guessing, because she said DC, and I don't know what it means, the full form.
DC?
So if the patient dies, to clean the warmer, to clean after the baby has died.
Yes.
Yeah. So if the patient has died, the cleaning has to be very thorough with disinfectants, not just with soap water. So you need to what is actually recommended is cleaning with soap water first, and then cleaning with a disinfectant before you use it for the next baby. And in case of incubator, you need to dismantle and then also clean.
Thank you. Next question to Dr. Praveen Kumar. Ideally, when birth weight should be recorded if the baby is being given skin-to-skin care after birth? Dr. Ruti Trivedi asked the question. Dr. Praveen Venkatgiri, can you please answer the question?
Yeah, I mean, I think it was answered in the lectures as well that there's no immediate need to do the weighing even up to 6 hours as well is fine, but make sure that the weight is being done. There's no need to immediately measure the weight.
Next question we'll ask to Dr. Shwetal Bhatt. This is from Dr. Bilkish Islam. Basically 2 questions, but you can answer them together. If the baby is less than 1.8 kg, when to start skin-to-skin care if the baby is stable? I think he means kangaroo mother care and not skin-to-skin care after birth. I'm not sure. And if the baby is 7 kg stable, should we admit the child in NICU or KMC directly? Dr. Bilkish Islam. Did you get the question, Dr. Shwetal?
Yes, sir. Yes, sir. Sir, if the baby is stable, less than 1.8 kg, we can KMC can be started immediately after the first feed. And even we do not, all the stable babies, low birth weight, do not require an NICU admissions, can be taken care in the KMC ward. These KMC wards are well equipped with all the, there is a proper monitoring with the 2 nurses in the KMC ward. So there is no question of, and regularly RBS and other monitoring is done. So it is as good as the NICU, but the equipments are less and more ventilated KMC wards are there. So less chances of infections and overcrowding is less.
Thank you. So there are studies going on for immediate skin-to-skin care or kangaroo mother care right from the time of delivery to be continued throughout the neonatal period when the baby is in the NICU or what is called as now the mother and neonatal child ICU. If you look at Indian Pediatrics, maybe a few months back, there's a publication from Safdarjung Hospital by Dr. Harish Chelnani and another person, a group. And so these are actually WHO-sponsored studies going across happening across 3 countries. And I think the results of that will be published soon. They are, I think, already been collected, but I am not sure whether they are published. But the protocol of that is definitely published in Indian Pediatrics. So it would be useful, and maybe we can discuss it during the KMC week. Question from by Dr. Barnali Bora, and the question is: can we use heaters or blowers to maintain 26 to 28 degrees temperature? Maybe Dr. Kavita can take this question again.
The heaters inside the NICU.
Yes, I think that's what is meant.
If it is cold, I think we should use it. I'm not aware, sir, because ours is many NICUs are central AC controlled, so we control the temperatures. But I think if it is cold, it's better to use a heater to maintain the temperature of in winter season, maybe. Yeah.
Okay, so we do use in our NICU because we are relatively colder, as we mentioned it. But many times in postnatal wards, and it does happen, and we should try and make sure that this does not happen. What people do is keep the warmer next to the baby's cot, and I have seen babies getting red skin because the blower or the heater is very close to the baby. This happened quite some time back. So we should definitely ensure that the baby is not very close to the room heater or the warmer. If this does happen, and we should make sure that the baby is not directly touching the heater. A question for Dr. Rita Bora. What should be the frequency of temperature monitoring in a baby not under warmer to screen for hypothermia?
Yeah. If the baby is on like skin to skin care, is a stable baby, would be monitoring less frequently, around 1 hour or 2 hours. But for a sick baby, it has to be a continuous monitoring.
Yeah. So if the baby is healthy and not under the warmer, and baby is in skin to skin care, maybe every few hours, every 2 hours or so is the answer. And if the baby is sick and under the warmer, then maybe continuous, and maybe not. It should be continuous skin to skin care, continuous temperature monitoring. So we are coming close to 1 o'clock, and I will maybe ask a few questions more. Let's check. Dr. Ruti Trivedi asked, in case the baby is stable on O2 in this COVID era and also routinely, should mothers be allowed for KMC in the NICU? Can't it cause sepsis is the question. I will ask Dr. Praveen to speak about it.
No, nothing to worry. Actually, that's not correct. The sepsis won't increase, and anyway, of course, ensuring that mother also takes a bath and comes clean. So we should not have that fear. And in fact, mother's own milieu of bacteria will come to the baby itself, which is a positive. Sepsis will not increase. Follow normal infection protocols.
Yeah, so Dr. Rutvi and NNF along with the IIP has published a guideline with respect to this, and it clearly states that kangaroo mother care should be given for all such babies. And it's probably one of the best guidelines, because this guideline was compared with other guidelines across the world, and the NNF guideline was supposed to be was rated as one of the best across the world. So it's something which you can look up, and it's, I think, published in Indian Pediatrics and is freely available. So I think we have reached 1 o'clock, and we still have a few questions left. I think we can stop here, and I will hand over back to Pratima for any more questions. So thank you all the faculty for doing some excellent presentations and answering the questions in the chat as well as answering them. It was a very interesting session. Hypothermia might seem to be something which is common or easily manageable, but it is still highly prevalent and definitely does have long-term impact as well as short-term impact. And we should never lose sight of the fact that hypothermia is something which we need to manage on a regular basis and ensure that all the leaders in the NICU and across the organization give a lot of importance to it. So unless we are able to do advocacy for newborn in other forums, we will not be able to ensure that we bring down the levels of hypothermia to lower levels from what they are currently. I thank Dr. Devrari and NNF for involving me in this course and being able to moderate this. Thank you very much.
Thank you.
Thank you, sir. Thank you, all the faculty members.
Thank you.
Lord, everyone.
Thank you, sir.
Dr. Devrari, you want to say anything at the end?
Yes, sir. Devrari, sir, would you like to?
I think this was excellent session. A lot of questions which are answered and moderated very well. And all the faculty did a wonderful presentation. Great learning. Thank you so much. Thank you, Praveen, Somasekhar, Mala, Kavita, Pratima, Rita Bora, and everyone. Rita Bora is traveling. She is in New Medical College. All the best.
Yeah, and Dr. Pratima for making sure the backend works completely well and managing everything.
Yeah,
and,
Pratima,
I think
Pratima is responsible day-to-day management of all this platform. Pratima.
Absolutely. Yes. Thank you, Pratima. Thank you so much.
Thank you.
Thank you, sir. Thank you. Looking forward to learning next Sunday too.
Yeah.
Yeah. See.